everyone. Welcome. This is our first IEHP Health Education Forum that we have done virtually. So this is our grand experiment, and so far so good. We're really excited about it. My name is Alison Elsner, and I'm the chair of the IEHP. I'm also the executive director for the San Bernardino County Medical Society. So we are a partner with the CHI, obviously. And we're just really, really happy that you're all joining today. We have some wonderful panelists, and we're going to learn a lot. As you know, of course, this event is in honor of May being Mental Health Month, and we do want to extend an enormous thanks to our very generous sponsor today, which is NAMI, the National Alliance on Mental Illness, and a thank you to Kevin Mahaney with St. Mary Medical Center for securing them as a sponsor. And that's NAMI Woodland Valley, I want to point out. So thank you, NAMI, and thank you, Kevin, for your work and your partnership on that. A couple of housekeeping things as we get started. We are going to have everyone muted. This is going to be similar to a webinar. So just to cut down on the background noise and interference, because we want to be able to give our panelists the floor. We want you guys to speak without interruption, because this is all about you guys today. And we're going to be looking forward to learning a lot from all of you. This meeting is being recorded, and following the meeting, probably sometime, I'm assuming later today or tomorrow when we can get it up on the website, it will be on the IEHP website. So it's iehpi.org. Okay, so you can check for that. And when you're looking at that, what you're probably going to find are some questions. At the end of this session, after all of our panelists have had a chance to make their presentations and respond to the questions we're going to ask them, we will have time for audience questions. And what we'd like to ask you to do is please use the chat feature on your Zoom screen, and you can go in and you can either, well, I think the best thing to do so everyone can see the questions is just go ahead and ask your question. And if you have a particular panelist you'd like to direct your question to, please indicate that. Please say, this is for Dr. Frausto, or, you know, this is for Dr. Bond, or however you'd like to do it. So we will get to as many of those as we can at the end of this session. Now, for the ones we don't get to, that's where the recording will come in handy on the website, because we're going to share that with our panelists, and we're going to hope and ask that they might take the time at their convenience to respond to those questions, so we can get them all answered, even if we can't fit it into this session. So with that, I think we're going to go ahead and get started. As you know, the title and the theme of today's presentation is Mental Health Delivery in a Time of Crisis and Beyond. And at this time, I would like to go ahead and welcome Arlene Molina, who's been instrumental in putting this presentation and this panel session together. Arlene is the Deputy Director for Health and Mental Health for San Bernardino County Preschool Services Department. So Arlene, take it away.
Thank you so much, Alison. I am just going to take a few minutes to introduce the IEHP board members and the mental health task force members who collectively planned this and got all of the kinks out so we can be here today. Alison, of course, is with the San Bernardino City Medical Society. Thank you so much. And she is the chair of the IEHP. We have Gary Roto with Borrego, Lisa Schifano with RCOE, Alexandra Bravo with Molina, Kevin Mahaney with St. Mary's Medical Center, and Ronnie Thomas with First 5 San Bernardino. So thank you, IEHP board members, and the mental health task force members, Melody Amaral with Wiley Center, Glenia Uloa with RCD-MH, Yvonne Roche-Joseph with Neighborhood Clinics, Sandy Sanchez with Community Health Organization Inland Southern Region, Mark Anthony Paredes with Blue Shield. And we also have Felix Perez, who will be kind of emceeing our event. And he is the Program Development Specialist of Mental Health with Riverside County Office of Education. He's been there for 6 years, and he works, he has a credential in pupil services as well as, child welfare and attendance. So thank you so much, Felix, for taking care of the emceeing with the panelists.
Thank you, Arlene, for transitioning us into the meat of the presentation. And with that being said, I'll give you a brief summary of our current presenters, and we have some questions assigned so we can move forward and provide the beautiful information across our Inland Empire services. Our first speaker is Teresa Frausto. Dr. Teresa Frausto currently serves as the Chief Psychiatric Officer for the County of San Bernardino, Department of Behavioral Health, and Medical Director of the Alcohol and Drug Programs. In her 18-year tenure with the county, she has worked in the behavioral health outpatient clinics and as a clinic medical director for juvenile detention and assessment centers. Her role at the Department of Behavioral Health encompasses a broad range of medical services, including diagnostic evaluations, acute outpatient stabilization, medication management, crisis intervention, integrated health, and brief focus psychotherapies for people experiencing serious and persistent mental illness. She also works to provide education, training, and clinical experiences to future behavioral health medical providers in collaboration with various teaching institutions in San Bernardino County. Dr. Frausto is a member of the Board of Directors of the San Bernardino County Medical Society, helping to advance the society's goals in insurance quality, access to care for patients throughout the region. Our next panelist is Dr. Wendy Vieira. Dr. Vierra is a Director of Behavioral Health Operations for Neighborhood Health Care. She has served over 20 years in behavioral health care servicing the diverse needs in low-income indigent patients, severely emotionally disturbed patients, Native Americans, LGBTQ community, cancer and hospice patients, and commercially insured individuals. She has a PhD in behavioral health psychology from California School of Professional Psychology and an undergraduate degree in psychology with minor in physiology from San Diego State University. She is dedicated to improving the lives of those she serves, the community they reside in, and positively impact behavioral health changes at a state level. She thrives on building collaborative partnerships with key stakeholders to remove barriers and improve access to service those in need. She has extensive experience designing, implementing, and managing high quality and cost-effective programs using data-driven tools to direct services needs and transform how we can deliver care to those in need. Dr. Vieira is committed to address social factors that have substantial impacts on health-related outcomes. She welcomes opportunities to share ideas and information to improve the lives of the patients we serve. Next, we have Laurence Gonzaga. Laurence is a behavioral health county program liaison with IEHP. He works on mutual interests between managed care and the county mental health and substance abuse departments, identifying issues for improving and working collaboratively with them to resolve them. He's also an adjunct professor of psychology and child development at Chaffey and Valley Colleges. He earned his bachelor's and master's degree in psychology at California State University, San Bernardino. We also have David Bond, LCSW. David Bond is licensed clinical social worker and board certified expert in traumatic stress with career dedicated to serving vulnerable populations. He's a director of behavioral health at Blue Shield of California, Promise Health Plan, where he leads initiatives to restore, sustain, and enhance the behavioral health and well-being of California Medi-Cal and Medicare beneficiaries. David also serves on the Human Subjects Interview Review Board for Behavioral Health Studies at USC. Before joining Blue Shield, he served as Vice President of Programs at the Trevor Project, a leading national organization providing crisis intervention and suicide prevention services for LGBTQ youth. At Trevor, David developed and enhanced 24-hour crisis services to digital platforms, launched national suicide prevention programs, provide leadership on numerous national, state, and local policy initiatives. Before that, he was a manager of youth development programs at Radius Children's Hospital in San Diego, where he designed and led psychological departments and healthcare career pipeline programs for high school age youth living in San Diego's most impoverished communities. He also directed the Radius Children Wellness Team, which provides health education for incarcerated youth. For 10 years, Mr. Bond was a practicing psychotherapist specializing in children and trauma. He has taught and lectured widely on topics of physical and sexual abuse, domestic violence, suicide prevention, clinical and policy considerations for LGBTQ communities, access to care, and program evaluations. So as I introduce our panel, we will have a series of questions. The first one is for Dr. Teresa Frausto. How has the mental health delivery changed because of the pandemic?
Hello, good afternoon, everyone, and thank you for having me on today's program. San Bernardino County Department of Behavioral Health is the safety net for treating the Medi-Cal population who have severe and persistent mental illness and functional impairment for adults, and also for children who have mental illness or have mental illness that may affect their developmental trajectory. Our county mental health clinics and contractors serve about 60,000 individuals every year. The pandemic has certainly changed the way we deliver mental health services. All of our mental health and substance use disorder and contractors have remained open. All of our clinics have remained open throughout this pandemic. We have skeleton crews who have remained at the clinic with the majority of our staff telecommuting and providing telephone and some video conference appointments. The staff have been extremely busy orchestrating all of these new changes and for the service delivery. Essentially, within a matter of 2 to 3 weeks, we revamped the whole outpatient delivery system. It was quite challenging and at the same time very allow for a lot of innovation. And we constantly seek for those silver linings, and there's been many. Our patients, for example, are very thankful that their doctors can call them at home on a non-pandemic day. They have so many challenges to getting to appointments, either transportation, childcare, or other medical health problems that really make it hard for them to get to their appointments. And they are so appreciative that the doctors are calling them. And our no-show rates actually have decreased because of that. The staff in the clinic and those patients that do have to come into the clinic to be seen are all being screened for COVID and are having their temperatures taken, and everyone is wearing a mask. Everyone is wearing a mask. I just want to repeat that. And again, while it's been very challenging, our staff and our patients have been adapting and are truly, truly resilient. Of course, we have had some patients that have decompensated during this time and require hospitalization, but we have not seen our numbers change. The number of hospitalizations has pretty much remained the same as before the pandemic. The other thing, well, DBH has a long history of working collaboratively with our county partners and with the community, and these relationships have only strengthened during this time. Our motto is San Bernardino Strong and San Bernardino County Together. We have been actively involved in the COVID County's response team. Our staff are located at each COVID testing site throughout the county, working side by side with our public health partners. Our staff are providing the support there and also giving information and community resources to those who are interested. We've also established COVID-19 warm telephone lines and text lines for the community. We have seen an increase in the need for mental health support in the population that does not have severe mental illness. We are also helping feed our community. Our homeless outreach support team and other engagement teams are busy helping deliver food to Project Room Key and the governor's trailers at Glen Helen and to others who have food insecurity. And as you know, our skilled nursing home facilities have really been hit hard by the COVID-19, and our teams are going out along with Arrowhead Regional Medical Center and public health teams to each skilled nursing facility in our county to provide training, personal protective equipment, and other mental health resources. We quickly noticed how stressed the staff were at these nursing facilities, and we were able to arrange group therapy for them, for those who were interested in. We also are continuing to work with our school districts to make sure that our children are receiving mental health services. And finally, I'd like to remind everyone that, again, May is Mental Health Month, and to please wear your lime green to represent mental health. And thank you again for having me today.
Thank you, Dr. Frausto. Is there any additional or questions that we might need? Now we can go on to our next presenter, our next panelist, Dr. Wendy Vieira. The question for you, Dr. Vieira, is what changes might continue as part of the new mental health landscape?
Thank you for having me. Very happy to be here. I'm with Neighborhood Healthcare, and we've got 16 clinics in San Diego and Riverside County. We are very similar, it seems, to the same population that Dr. Frausto serves. We serve about 76,000 unique people and about 355,000 visits a year. So we're pretty decent size. And everything that she just described, we've had to go through as well. We started out by changing our clinics to sick and well clinics. We had to close down clinics, consolidate any PPE and cleaning supplies we have, and then redistribute it. We had to repurpose staff, and you know, within days, provide remote access to hundreds of our employees. So it was like, you know, turning the Titanic, but we did it. It's phenomenal how you know, in crises, people are able to kind of come together and just do what you need to do and be flexible. And we have an absolutely amazing IT team who has helped to make that take place too. So some of the changes that might continue as part of this, you know, first, all the changes that we had to do, that we are providing home services. About 90% of our services right now are virtual, meaning that they're either telephonic or video at this point. A lot of how much of that will continue is going to be completely dependent upon the state and the government and what they're willing to reimburse. And you know, it's been great that they've relaxed a lot of their guidelines, but certainly we expect some form of coming back and providing oversight. We don't know what that'll look like. A lot of people, there's all sorts of predictions out there that, that possibly telephone may go away and just video, or that PPS rates may need to be renegotiated. So we'll see what happens there. But we would like to do it because what we've also seen is we've traditionally had a no-show rate of about 25% that's gone down to almost non-existent. And I hope really what our state and governors and government hears from us is that we are now truly meeting the needs and the pent-up demand of our patients. Clearly transportation, daycare, and all these other barriers are what is driving our no-show rates. So being able to provide access and meet them where they're at their home is critical, I think, to be able to serve the population that we serve. So we're hoping that that will continue. What will also continue in our mental health landscape is we have canopies in front of every clinic. Everyone, just as Dr. Frausto was discussing, is screened not only for COVID, but have you been in contact with anyone? Everyone, including all of our staff, every day, we have their temperature taken. We're also documenting our staff name and temperature every day that's taken. Everyone wears masks. We've gotten rid of most of the seating in our lobbies so that chairs are 6 feet apart. We disinfect every chair, every stand, anything that any patient touches. We now have employee and patient bathrooms. Patient bathrooms are disinfected after people leave. And then we've also divided our clinics now into sick and well sites, so that if someone does have symptoms or appears to have been in contact recently with someone, we're going to divert them to a small side of each clinic where we have selected offices and people in full PPE that will address their needs there. The other thing that's changed for us is how we do forms. So normally somebody will come in 30 to 60 minutes ahead of time to do all their intake forms. Now we're texting them. So we're going to be doing a lot more of that. We've done several Kaizen events here at Neighborhood where we are trying to take advantage really of this time of flexibility and create a lot of change. I mean, there have been so many silver linings, as she just spoke about, that we're finding a lot of opportunities to be more efficient in change roles. The last thing that we have adjusted to is medication-assisted treatment. So very quickly, we had to adjust how we were providing those services. We now provide home inductions, and we do it through telehealth. What we do is we expect a patient to go to one of our clinics ahead of time, and they'll do the urine drug screen, labs, vitals, anything that we need there. And then our provider will have either a telephonic or video visit with them. And we're now very comfortable doing home induction, which was something we were just starting prior to COVID. Any questions on that?
I think our questions are being submitted on the chat feature. So if there are questions at the end, Dr. Vieira, we'll go through those and present them to you then.
Perfect, thanks.
Thank you, Dr. Vieira. I think we're all just getting used to this virtual thing. I keep forgetting to unmute myself and mute myself. The next question is for Mr. Bonds. What new methods of mental health treatment or services will be covered by mental health insurance? David? Did we lose David?
No, I'm here. I was
Okay.
double muted. I apologize. But I did want to say thank you again for inviting me to be a part of the panel. I appreciate this opportunity. Mental health services delivery has changed quite a bit just in the past few months. We have offered, I first mentioned that Blue Shield of California offers Medi-Cal in San Diego County and Los Angeles County. And I spend most of my time working with Medi-Cal and Medicare populations and managing the behavioral health benefits and needs for these populations. But I would say we had telehealth before COVID, but have significantly expanded our offerings, largely in part of changes that were made at the state level and what the Department of Healthcare Services has now permitted. One of I think the most important changes for telehealth for Medi-Cal is that Medi-Cal now allows telephone only visits between providers and their clients, where previously Medi-Cal beneficiaries were restricted only to like HIPAA compliant technologies, and they had to have a smartphone or a tablet or a computer. And many people with low income just don't have that kind of access. So allowing people to just use the telephone to have their appointments with their provider has been quite a change. Just in Q1 of this year, we had more telephone therapy appointments than in all of 2019 combined. Which is particularly fascinating when you consider that the shelter-in-place conditions didn't start happening until March. So we had quite a big spurt there, and I'm very eager to see how that continues month to month when we get to the end of this quarter. We also had a higher number of unique utilizers of telebehavioral health than all of the unique users of 2019 combined. You see a massive surge there. I think in addition to this, there's also a real look at, I think I'm preaching to the choir with all sorts of mental health folks on the panel and participating, but there is no health without mental health, and we can only provide, we can only apply, as a payer, we can only serve our members to the ability that our providers can serve our members when it comes to treatment, right? So we've actually put in quite a bit of focus on taking care of the helpers, with some additional webinars, some other compassion fatigue and burnout exercises and sessions, as it were, as well as some additional trainings relevant to substance misuse and suicide prevention in particular. I would also say we have, when you think about social determinants of health as well, which I know is a catchphrase for many people, but for many of us in the field, we've been saying it for 20 years since grad school, right? Where social determinants of health really have to do with financial and political arena that someone lives in. And so with so many people having lost their jobs and now experiencing either maybe a housing crisis, or they have food insecurity or housing insecurity, there's another thing that a lot of people don't realize, that Medi-Cal managed care plan, like Blue Shield of California promised, where we have a whole team of social workers who have open and active social work cases with our members. So it's not just providing access to healthcare providers or providing access to mental health care providers and then paying for it. It's also making sure that we're addressing like a whole person, because all of those things play a real factor in overall wellness. So whether it's assistance, a connection to legal assistance, financial assistance, or like I mentioned, housing or food insecurity, there's really, in times of COVID and shelter-in-place conditions, all of these things have these big spikes, right? So you can't just say, do I have access to a therapist, and say, well, that's all I need for mental health. Or do I have access to my medication? That's all I need for mental health. It's really a whole biopsychosocial approach. That was my response to the question.
Thank you, David.
There was like long pause. And I'm like, I can be more verbose if you would like. I want to make sure I don't take up more space than was permitted by just one question.
No, that's perfectly fine. Any other questions, or does anybody else would like to share on that as well? Now we can go on with Laurence to our next panelist. No.
One more thing I would mention too, as we look at changes, diagnostic categories for people seeking treatment have changed and shifted. So we used to look at like top 5 diagnoses among people who are seeking treatment, and they have now changed during shelter-in-place conditions, where our top 5 are major depressive disorders, PTSD, and then 3 different types of anxiety disorders. So it's all anxiety and depression, where previously a lot of people were going for like medication management for ADHD, whether inattentive or hyperactive type, and that's really fallen to the bottom of sort of diagnoses that people are seeking telehealth services for.
Great, that's good to know. Thank you. Our next question is for Mr. Gonzaga. Laurence, I think I'm on mute. No, I'm not. What do you see as a major challenge for specific groups, such as seniors or at risk? Can you please?
Sure. Thank you for inviting me to be on here. Thank you for also limiting me to one question, because I don't think I would have been able to do a better job than the other panelists. The other thing would be, I hope you don't mind, I will mute my video because I am easily distracted by moving things on my screen, so I can get through my notes here. So recently, what we did at IEHP is our research analytics department ran a report to pull our members that have 2 or more chronic medical conditions, because we were asked to do a sort of a targeted outreach campaign for our members. And so I think just in Yucaipa City, we had 2,000 members that we were doing outreach to. Like, you know, our staff took time out of their days to do these outbound calls. And we had about a 20% success rate, which is not too bad as far as call campaigns go. And 1/3 of the reasons why we were unsuccessful is that we didn't have accurate contact information. And that information comes to us, you know, from the state, so the Medi-Cal system has their current information. But as we did try to do those outreach calls, we, you know, 1/3 of those, you know, 80% of unsuccessful outreach attempts were due to disconnected lines or, you know, changed phone numbers, things like that. So that's certainly still an ongoing challenge. And the reason for those calls are to check in on our members to make sure that they have all the resources that they need. IHP invested recently in an app, a tool that they can use called Connect IE, which they can access on their phone. So we informed our members about that resource, as well as 211 and you know, just basic information about COVID-19, things like that. As far as other specific populations, so for our seniors, you know, what we were hearing is, you know, just and it's true for any population really, just varying degrees of comfort using technology. So while we do have telehealth approved, I mean, using it effectively, whether it's a computer, phone, tablets, you know, those were, we've heard to be challenges, including software. So they might have the technology, they might have the tools, but not the software, you know, sort of savviness, whether you use Zoom or FaceTime or Facebook, and knowing the difference between all those things have been challenges. Lack of social support or support systems, family or friends, things like that. Isolation, security concerns. I'm pretty sure we've seen some of the emails coming around about the phishing scams that have been ramping up. COVID-related scams like, you know, pay this $49.95 and then, you know, fee will send you a COVID test that you could do in your home, things like that. I mean, obviously those aren't true, but those have been going around. For our children's population, it's actually been sort of positive in terms of, you know, show rates, I guess that's a term. Remote area, especially children that are in more remote areas, and you know, if they had transportation issues in the past, they're able to be seen virtually, whether in the county system or in our IEHP Tier 2 network. And of course, socialization has been impacted for our kiddos. You know, they're used to seeing their friends, teachers in school contexts, and going to the playgrounds and parks, but all of those have been closed off. So those have been challenges for them. Parents having to work from home. So if the kids have to do schoolwork, they might have a Zoom meeting scheduled at the same time parents have a Zoom meeting, and so that takes up bandwidth, and you know, juggling those resources are a challenge for parents and the children. We've heard that there have been increasing, while their no-show rates have decreased, outpatient cancellations have actually increased. And it kind of makes sense if you think about, you know, Maslow's hierarchy of needs. I think a lot of our families are in sort of survival mode. And so things like mental health, even though they were already ongoingly in treatment, have been put on the back burner. So we've heard that from Riverside County, outpatient cancellations for children's populations have increased, but they've also seen an increase in higher levels of care for children in the inpatient setting. So while they're not taking care of the outpatient needs, it might be escalating into higher level needs later on if not taken care of earlier. The health plan has the ABA benefit, which is applied behavioral analysis for our children with diagnosis of autism. And so I've heard back from our manager that manages this population that services have declined even with telehealth approvals, especially with families that have children that are nonverbal, as well as the children that have more challenging behaviors. The online virtual platform isn't working well for that sort of subset. For our adult population, no-show rates, I'm just echoing what's been said already, have decreased. One organization I spoke with had said they were in the 20s before COVID, now they're in the low teens. What has improved is for those adults that live in more remote areas, or they're suffering from agoraphobia, or they've had constant transportation issues in the past, they're now being able to be seen very efficiently through the virtual platforms. Language barriers also are an issue with technology. All these apps tend to be English only as far as instructions and how to use, how to use the tools themselves. So that's still a barrier. Taking off my IEHP hat and going into my sort of adjunct professor hat, hearing the feedback from my students, a lot of them are homeless. And before COVID, there were some community colleges that were allowing our homeless students to sleep in their cars overnight on campus, in the parking lots. There's school police, so it's fairly secure. They can use the resources on campus for hygienic purposes, and of course, with campus lockdowns, that's no longer a possibility for a lot of campuses. And what the feedback I've been getting from some of my students are some of the things I've already said. The most important, or the biggest ones that I've heard have to do with internet. So while they might have internet, they don't have reliable internet. So it's like the lowest level of bandwidth or whatever it might be. And there isn't any backup for Starbucks or libraries or campus libraries, things like that. So even though, they might have a Chromebook loaner from the college, they don't have reliable internet to be able to use that for their schoolwork. And that obviously adds, stressors to their, day-to-day. And that's all I have. Hopefully I was under or at my time.
That was wonderful. I'm going to jump back in here now. This is Alison. Thank you so much. And all four of you, Dr. Frausto, Dr. Vieira, Mr. Bonds, and Mr. Gonzaga, that was incredibly valuable information. As a result, I see we have many, many great questions that have come in from our group. So what I'm going to do right now is we're going to turn this over to Soteria Cobb. And I want to do something really quick before we jump into the questions. I want to thank a couple of people. I want to thank two members of the SBCMS staff. That's Janice Solorio, who is kind of doing all the behind the scenes operation of this Zoom call today. And I want to thank Soteria, who's about to come on, and she will read the questions aloud and direct them to each person if there's someone in particular that is being asked to answer. If there's not someone in particular being identified to answer the question, if it's just an open question to the panelists, feel free, our four panelists, to jump in and respond. But if you can do us a favor, just kind of make sure we want to have thorough answers, but we also want to fit in as many questions as we can. So if you can just kind of respond, and if you feel it's been responded, then we'll go to the next question. So Soteria, why don't you go ahead and start us off with the first question?
Sure. This question is for David or Laurence. Have you heard definitely if telephonic visits will continue to be billable after June 30th?
I can respond quickly and say that I've heard no information to the contrary. Everything that I've read so far from the state has been until further notice. So we have no intention of putting an end date onto it just yet.
Okay.
Same
The next
for me.
Oh, I'm sorry.
I was just saying same for me.
Okay. The next question, I think, is for everyone from Dr. Pai. It is, what are the mental health services available to the SNF patients from the county mental health?
Yes, this is Dr. Frausto, and we certainly have an access line to take intakes, and we can see if those patients in the skilled nursing facility qualify for county mental health. Again, county mental health is the safety net. It's for the Medi-Cal and uninsured patients who meet medical necessity. Our mandate is to provide for the severely persistently mentally ill with functional impairment. We work very closely with our healthcare partners, Inland Empire Health Plan, and as well as Molina. And so depending on also their insurance that they have, will depend on what resources are available for them as well. And now we'll get that number for the access line to you.
Okay, thank you, Dr. Frausto. The next question is for David. Do you have data on usage of mental health services by frontliners, specifically hospital employees, since onset of the pandemic?
I'm afraid that the data that I have probably won't really be helpful for the intention behind the question. I could talk to you about the number of people who have been participating in our sections online, but in terms of people actually pursuing mental health services, obviously it'd be quite private, and we don't have that sort of information. I will put, though, in the chat box, I've just put in a link to our coronavirus provider resources that are for mental health. Well, anybody could take a look, but they're specifically for mental health providers and include several upcoming webinars specific to a number of topics relevant to this conversation.
Okay, thank you. The next question is for everyone. Are there any state proposals, health providers that are supporting in order to continue providing telehealth services? Are the barriers to continue telehealth services after COVID-19 on a federal or state level?
I would say it depends on the, to use the term, but line of business that the member has. So if you have a commercial health insurance, that's going to be a bit distinct from whether you have Medicaid or Medicare, and depends on which state you're in. So the barriers to telehealth, I want to first state that Medi-Cal has been available, many services have been available for Medi-Cal over telehealth already. It's really just the telephone only piece that is the newest piece, and a couple of other additional services that are now payable at the same rate. In terms of barriers for it, I also want to mention that providers, many providers, almost no providers, and certainly no one from my generation or older got any training on telehealth utilization while we were in grad school. I mean, like, the internet was pretty new at the time, right? So many people were a bit averse to it and thinking like, this is maybe a whole different skill set. And if I don't have a person in the room, how am I going to be able to do actual therapy? But very surprisingly, I have had many providers say that they have suddenly become much more comfortable providing telehealth now that they are sort of forced into it. They're actually able to see more clients and are sort of getting to know clients in individual therapy in new ways. Like someone says, hey, this is my cat, and suddenly that you never could do in a therapy session before. And so pieces of like getting to know you and some of that rapport building that you might think you have to do in person is now somehow more accessible over telehealth as well.
I want to throw in a little extra thing for telehealth for FQHCs has not always been available. It is, but only within our 4 walls. So I think it's important to kind of understand those rules around getting reimbursed. And the 4 walls rules means that a patient has to be at one of our clinics and our provider has to be at another one of our clinics. So it's only in between clinics, and it's not necessarily removing the access barriers of, you know, of transportation and daycare, and I could lose my job if I take time off. So we have not always been able to provide telehealth. We're hoping, because I mean, obviously the visits are going through the roof, the virtual visits. I hope that, you know, everyone in our government and our insurance plans and everything are listening and seeing that the people need this, and that we need to have that flexibility to provide service in their home, whether that's telephonic or video or however that is. But for FQHCs, we've had to do that with our hands behind our back. So it has not been easy. It is now. Now it's very, very easy. We're hoping that these things don't go away.
Exactly.
Can I
Thank
add
you.
something also? This is Alison with the Medical Society, and this question was presented by, thank you, Karina Tomeo from Office of Senator Roth. You're specifically wondering if the barriers are coming from the federal or the state level, and I think there are issues at both, and there are concerns at both that what's been established through COVID-19 is not going to be continued after the crisis is considered to be over in terms of telehealth waivers and parity for providers. So that's the big concern, Karina. And as I mentioned in the chat, the California Medical Association, we are engaging in heavy advocacy right now to reject the governor's budget, that separate issue, Prop 56 funding, which will hurt access to care. But our concern is that there are no provisions in there from the governor's side to continue those telehealth waivers and provisions that will make providing telehealth financially viable for providers. If that is not done, if there's no insurance for that, then again, that's going to affect access to care by telehealth. So we would ask you, Karina, to go to your boss and ask that he respond to the governor's budget that will be coming up for a vote, and ask that be included in the budget. So that's just our take on it, but I want to mention that's an important thing that has to get in there. There has to be funding, and there has to be protections for that in order to protect the telehealth structure. Sorry.
And I would also like to chime in on that very similar to the FQHCs, our county has been doing telehealth for years, if not decades, but it's within intra-system, not from without. And the California Behavioral Health Directors Association is also actively advocating for the continuance of this telehealth that has been shown to really be a silver lining for our patients and the delivery of health services, which the coronavirus is, as far as I know, not going away quite yet. And so we're going to have to continue these services long after. Thank you.
Great.
Oh, I also have the number for the access unit, and that's 909-386-8256.
Great. Janice, will you post that on the chat, please? Did you write that down from Dr. Frausto? And can you put that on our chat so people can see it?
Thank you.
Thanks, Dr. Okay, so Daria, why don't you?
Okay, great. The next question is for David. Can you share about the current behavioral health services within the Inland Empire offered to covered California Blue Shield members?
Hi, I did put a little bit further down in the chat the best person to contact at Blue Shield, who is from that outreach team, who would be able to provide the best level of details about covered California. It's just a little bit outside of Inland Empire isn't my strongest scope, so she's the subject matter expert to connect with.
Hello, this is Edith Laura from Cover, California. If I may add something to that response.
Sure.
Yes, I just asked that question to sort of open communication regarding the offerings since David was presenting regarding Blue Shield, but just to let you all know that Cover California and all of their health plans has behavioral health packets. And most of our plans that are serving the Inland Empire also have telehealth within the behavioral health realm. And we have 5 plans serving the Inland Empire, including Blue Shield, Kaiser, HealthNet, Molina, and Anthem Blue Cross. Thank you.
Great, thank you. Now, this next question is for everyone. How are the different plans, county, combating misinformation about this pandemic? What are some strategies, approaches you can offer when it comes to promoting the well-being and education of our community as it relates to COVID-19?
I can speak for our department. Our director, Dr. Veronica Kelly, has regular town hall, WebEx, Zoom type meetings, and this has been very helpful to get information out to our staff in DBH and actually also to other staff in the county also will listen in. So this is again via WebEx and Facebook Live actually. And this is done on a regular basis, the town halls. And then she also has something called the Director's Minute, where she gives information on self-care and really important, most recently on self-care for healthcare providers, which was very well received. And we also encourage our staff to not be on social media all the time as well. That doesn't, I don't know all the research on that, but it certainly does not help to be watching the television and the social media all day long. We need breaks from that.
So I know IEHP has recently launched a podcast. The 2 hosts are Dr. Gayani De Silva, who is our medical director. She's a pediatric psychiatrist. Is that accurate? I don't know. But she and our clinical director, Amrita Rai, host this podcast, and there's 3 episodes so far, and they've tackled COVID issues at every episode, but it's mostly to do with self-care and tips and tricks to how to get through this pandemic. So and it's a weekly podcast, and it's on is it Apple and Yahoo and different platforms. Other things would be, we have a strong social media. We have an internal in our company. We have an internal audiovisual media, team that does, weekly broadcasts for our own staff members to benefit from, as well as, short little videos that they push out through our YouTube platform and other social media platforms.
If I could jump in on this question as well. I had a conversation once with someone who worked with a county water system, and I asked him about how he kept the water supply safe. And he said, the solution to pollution is dilution. And what he meant was, if you flood with a lot of clean water, then the pollution kind of gets out there. And the same thing, I think, applies to misinformation. So kind of like Dr. Frausto and Laurence just mentioned too, is like if we really flood with correct and accurate information that's to the best of our knowledge, we start internally with our medical leadership cascading to the rest of leadership in the organization, and that information gets all the way out to our customer care representatives and our social workers and our people who will go out into the field and everyone who answers the phone. Then you're flooding with accurate information, and the pieces of misinformation can be more easily turned into That's not what I heard. What I really heard was this, to make some of the, to change some of those cognitive distortions and really just address people's anxiety that comes up with ideas about what could go wrong.
David, I love that. I think that was great. And we're doing, I mean, same as everyone else is saying, we're doing a lot of that. We have our medical director as part of the COVID task force in San Diego County. So he sort of has the latest, greatest updates. As you know, very early on, things were changing like weekly as we get more information. And we were having daily COVID meetings during lunch with all of our leadership, and then our leadership would then cascade that down. At this point, we're now having weekly because we do have some sort of stability, if you will, but we do still have weekly meetings with all of our leadership. We have emails that will go out from our medical director and our CEO. And then we also have 2 outreach teams. During part of this, I loved all the things that Laurence was saying about the high-risk groups like our seniors. So we actually we've repurposed a lot of staff, and we repurposed staff to actually call, for instance, our seniors and do outreach. And they have a series of questions to ask them, you know, about all the things that he was talking about isolation, depression, anxiety, you know, if they have medications, do they need a refill, food insecurity, do they feel safe, all those things. But in addition to that, we're asking them if they have questions about COVID, and then using that opportunity to educate them and respond to their questions. But we're also letting them know, hey, would you like to talk to your primary care right now? Let's set you up with a phone appointment. So we're doing a lot of those type of things to also dispel, you know, a lot of the miscommunication out there. So we have 2 very active patient outreach teams that are just doing that, to check in with people if they have questions and give them the opportunity to talk with their provider if they feel they need.
Wonderful. The next question is for everyone as well. We've heard many of your providers are struggling because of the reduction of patients seeing services. What can a plan or our community partners do to help assist with this particular issue?
That would not be our experience at all. Almost all of our panels are full. It is, I mean, opening, I mean, now everyone's attending their appointments. I mean, it's just been phenomenal. So, and we're seeing also a lot of non-traditional people. And what I mean by that is people that don't have a mental health or behavioral health history. We're seeing a lot of folks with just anxiety that want to be able to talk with someone in behavioral health. So honestly, we've had no problems whatsoever filling up our schedules for behavioral health, speaking for behavioral health.
Yeah, I would agree with that too. I think with our behavioral health clinicians or providers that isn't an issue, but I would say that there are many other specialty providers. Like, people are canceling elective surgeries and elective procedures left and right. So we've actually, Blue Shield of California has provided over $200 million in funding for providers that are struggling now. So some of these applications have been for behavioral health providers. I've seen more like ABA treatment for children who have autism, because so much of that has required in-person work. But yeah, so like there are pieces, as you know, as a nonprofit provider, as a nonprofit entity, Blue Shield, you know, we don't have more than 2% of growth per year, and so any of the additional money that, you know, we're not spending on these sort of elective procedures or others, we want to make sure that we have available to give back to the community and make sure that our providers can stay healthy and viable and financially solvent.
This is Alison again. I'm sorry, I don't want to be a hog, but I do want to mention something because this is a really interesting question from Mark, and thank you, David, for that. You know, first I want to say Blue Shield has been an incredible partner to physicians and the California Medical Association. So this question is very timely because the CMA has just launched an initiative, because there are a lot of family practices who are literally going under. I mean, this is a huge economic issue for our physicians and our society. And so this, I'm just learning about it myself, but this initiative is called Care for Californians, and it does ask for health insurance companies to use premiums that have already been paid by employers, but have not had to be paid out by the insurance companies, to be put back into the system. Basically, they're asking to utilize unspent premiums for emergency prospective payments to ensure that primary care physicians can keep their doors open. So Mark Paredes, thank you for asking that. And again, you guys are an amazing partner with CMA and San Bernardino County Medical Society. But if you want to know more about this initiative, I'd be glad to get you more information on it. And it's something that's happening at the statewide level. I'm sure your statewide folks at Blue Shield are very, very engaged with the CMA on this already, but it's called Care for California's Initiative. And it is looking to reinvest some of those unspent premiums from the healthcare plans back into prospective treatments for the future. So we can try to keep doors open for some of these family and general practice physicians, which I'm telling you, it's a problem. They're closing their doors, and their layoffs are continuing, and there's a lot of damage that we've yet to see from this. So if you want to know more, Mark, I'll be glad to talk with you offline about that.
Great. And this next question is for Laurence. What is the percentage of community college students that are homeless, and in what areas of the Inland Empire?
Laurence, you're muted.
That's too bad. It was an amazing response, and I can't get it back. So, you know, it probably varies in different regions, as is implied in the question itself. You know, I teach at Chaffey College and Valley College, and an email I recall several months ago had said something like an estimate of 15% of our students. You know, I just did a quick Google search because I saw the question earlier. And there's an article I found on some website that said one out of 5 of California's community college students are homeless, and that could be defined different ways. I know even from the county perspective, how you define homelessness depends on the funding source of the services that are provided. So so that's what 20%, and I wouldn't know where it varies or it's higher or you know. But I do know the different colleges have different perspectives on continuing the or policies on continuing their support of the needs of our students. Like some colleges are like absolutely locked down. You know, you could go there and there's barricades. You can't even park your car there. And then you know, recently I'm part of a collaborative for TAY, transitional age youth. Collaborative here in San Bernardino, and I know we heard back from Valley College that they weren't preventing students from coming on campus if they needed to use the library or facilities or whatever it was. But you know, that might change from week to week. So hopefully I answered that question. So it's somewhere in the teens to up to the 20s.
And I would like to jump in on this one. I think that this has been particularly hard for, when I think about homeless youth, also we can't not mention that some 40% of homeless youth identify as LGBTQ. And so we're talking about folks who may have been able to get support, have social support, have school interactions, have connection to a gay-straight alliance in their school or in their university, but are now at home in what might be a supportive or a rejecting environment. And so I think that stress level and that complication of families that are going through a complicated time, or and particularly for these young folks who do not have the same level of comfort and care and acceptance in the home that they might have had elsewhere, that this level is rated even more for these folks. So just wanted to really kind of push out opportunities to access organizations like the Trevor Project, which is specifically there to support these young folks, as well as Crisis Text Line with, or the National Suicide Prevention Lifeline, which is always available 24/7.
I also wanted to state that that number probably is low, because oftentimes the college students might be couch surfing, and so that number probably is on the low side. And the county also has programs to support the transitional age youth, and specifically LGBTQ as well. We know that that is a high risk group, and also a high risk time in general, your early 20s for developing mental illness.
Maria, was that our last question?
Yes, that is the last question. I was just going through right now. Yep, that is it.
Would anyone else, since we have a little bit of time left over, thank you for being so frugal with your time, all the panelists. I know there's a lot more to talk about, a lot more you have to say, so we do have some more time. Would anyone else like to discuss any more of this in depth? Or are there any, let's open it up if you guys would like to verbally ask any questions.
The only thing I wanted to add that maybe we touched on a little bit, though, is that, you know, again, in this kind of time, we've had to do things very differently. And the social determinants of health, I really can't put enough emphasis on. Maybe where, you know, we've always assessed for this and provided people with referrals, but it's at such an alarming rate right now, people that are home and that have not had jobs in a long time. We also serve undocumented folks, so that, you know, jobs that they have that may have been on the side, or they may have no income at all. So we have had to do so much work. So a lot of our mental health work, if you will, has been done around getting people access to resources that they had no idea were available. And our communities come together, they all come together differently, but we've had, you know, drive by to get food. We have a lot of people, like I was talking about with our senior outreach, they don't have transportation. They don't have family checking in on them. And they used to come to our community center once a week for socialization. That's not available now. And so now we're working with our community-based organizations to deliver food daily to a lot of our folks and weekly to others. And also we've working with the county and some of our community partners to identify high-risk sick individuals and high-risk individuals that are well right now and put them in hotels. I don't know if your other counties are doing that, but in San Diego County, we have sick and well hotels that we've been putting individuals in. They don't necessarily have to be homeless, a lot of them are, but they do have to have the criteria of having, you know, being high risk, chronic, a lot of chronic illnesses, and not access really to social distance. So we've kept them in hotels for over a couple months. And I believe that will continue till 6:30 or until we hear otherwise. But things like getting people their prescription assistance, things we just don't think about normally. We expect our patients to get those. We're outreaching them that we all need to be asking, you know, do you have enough refill? Do you need assistance? And we're working with our pharmacies also to deliver those meds, as well as we've personally delivered meds, and we've had our community-based organizations do that as well. So I think that there's just, everything we do is a little more complex, and that we have to think a little more widely on things that our patients used to do themselves, they may now need assistance with. I don't know if anyone else had any social service things, how they're addressing those needs.
Hi, this is Maribel from San Bernardino. I was wondering if I could just add something.
Yes, of course. Please jump in.
So Maribel Gutierrez, Cultural Competency Officer for the Department of Behavioral Health. One of the things that we've been doing as part of my office is working with the Mexican consulate and the Guatemalan consulate to just see what kind of resources are also available for some of their citizens who are here in the United States. Maybe they were here and not able to return because they were visiting and now they're not able to go back. They have some issues renewing their visas to stay here a little bit longer. So just checking in with your consulates in your counties is a good resource.
Yeah, I'm so glad that you mentioned that, because when, you know, early on in this pandemic, we did not have enough PPE. I mean, we were just, you know, we're consolidating everything and being really very rigid about how we handed that out. Through this process, though, I mean, we all have such amazing communities. We've gotten donations like you wouldn't believe. We have more than enough PPE. In fact, we've had so much that we've been donating some to the Mexican consulate. So I'm so glad that you brought that up. And I think a lot of people may forget about those organizations, but there's a whole lot of donations that they can use. And we've been steering people their way as well.
Okay, great. Is there anyone else who had any other thoughts you'd like to share, or any other concerns you want to talk about? Or So I have one. For any of the panelists or anyone actually who's dealing in some of these fields. So I know we still don't know what's going to happen in the fall. We don't know if things are going to subside or if we're going to, you know, kind of be needing to expect a resurgence of COVID. But if there's a resurgence, do you feel that some of these things and these processes that have been put into place, it's at a structural level now, and that you will be able to kind of jump back into this crisis mode? And you feel we're prepared to do that, or what's your take on that?
For sure. I feel like, you know, those are those silver linings that, you know, it took a whole lot. It took a lot of people doing a lot of work to get those workflows in place, remote access in place, you know, to get those iPads and now, you know, and laptops, and now we have to have, you know, wireless headphones, and, you know, a lot of things that we just hadn't thought about, but you know what, we are so well prepared. If it comes again, it's, you know, and we anticipate it will come again. I think we will be able to adapt very quickly. I mean, within a day or two, we are prepared for it, I believe.
Awesome. Any other thoughts on that?
I think so
Yeah,
too. We certainly have had a lot of lessons learned. We also participated with the hospitals, the medical society, in planning for the surge. There was quite a bit of work being done 24/7 to make sure that our hospitals had the capacity. And fortunately, our mitigation strategies were very effective, and we, knock on wood, did not have a surge, but we certainly are prepared if and when we have a surge, and we can quickly set up alternative care sites throughout the county of San Bernardino if our hospitals do reach capacity. And that took multiple agencies working together. And I want to thank the medical society that was also very supportive of all these efforts. So yes, I think that we are prepared.
Well, and you know, Dr. Frausto, you're being very modest because you actually oversaw a lot of that effort through the task force throughout San Bernardino County, through behavioral health and public health and ARMC and all of the partners that were involved in that. We know how heavily involved you in particular were in making sure that those surge overflow sites would be available. I mean, you all planned really meticulously for that, and you were ready. You were stocking and supplying and staffing those sites up to the very middle end of April, until it looked like maybe it wasn't, fortunately, it maybe wasn't going to happen, but you were still ready. And I know you were looking to place homeless and mentally ill challenged individuals in those sites, and you had it literally ready to go if needed. You were ready that week, I think, the middle of April, when that surge was expected. So thank you for that. You did a lot of work for the county, and had it happened, it was just could have gone either way there. I think for a couple of days, because of what you did, it would have ensured, you know, a safe environment in the hospitals throughout the rest of the county. So thank you for that.
Well, it was certainly a good exercise for planning, and fortunately we did not need it.
David,
I would say, so if I can jump in on that one, you know, all of the managed care plans throughout the state have disaster response plans, but they're really for things like forest fires and earthquakes, so we can make sure people have access to their prescriptions and that sort of thing. I don't know if you could really prepare for something. I would not know how to better prepare for something that was completely unexpected. It was a brand new experience for everyone involved, including the lawmakers. But you know, we've just in the past couple of months, you know, relevant to COVID, and I'm reading a list, there have been 12 federal laws, 18 all plan letters from the state, 26 CMS mandates, and a covered California mandate. So when you're talking about all of that level of responsibility and regulation to make sure that we're doing, one, following the rules, and two, providing the highest quality services at the lowest possible cost, all while trying to figure out how to keep our own employees safe and healthy, and take care of providers and members. I think once you fall in the well, you only have to figure out how to climb out of it one time, and then if you fall in again, you know how to get out because you've been there before. So I think that that with experience comes preparation for the next time. And I think whatever happens moving forward, so from my own experience, my wedding was supposed to be next Friday in Europe. So it's been pushed for, thanks, I don't mean for the sympathy, but as much as it was heartbreaking, but we pushed for the wedding will be next June. But the whole thing was already planned. So I don't have, it's a whole nother year of really just kind of waiting for the plans that I already made. I don't have to replan a whole new thing. It's already, the template's there now.
Well, that's a really good point. The template, I think, for a lot of these structures is there, and the implementation will have to take place again. But you're right. That's maybe 50-75% of the battle is knowing exactly what to do and the timeline on which to do it. So that's good. That's encouraging, and it's encouraging on behalf of our healthcare workers and providers, because that's who really gets thrown into it there. So that's reassurance, hopefully. Okay, anything else? No other questions or thoughts? Okay, well, a couple of things then before we wrap up. We do want to remind everyone that we are planning our IEHP annual legislative forum. Normally that's held in January, and this January we didn't have COVID yet. However, we had some issues with some scheduling conflicts for some of the legislators, so we decided we were going to push it into late spring. Well, then of course that became impossible. So we have it planned for Friday, September 11th, actually, but we don't know yet. Of course, I'm pretty skeptical myself as to, our ability to hold in-person gatherings. I highly doubt that. September's right around the corner, but who knows? But if not, we will have a virtual meeting, and we will have some featured, we try to have 3 or 4 featured legislators lead that, and we'll have a theme and some questions. It'll be kind of similar to this, but with, we'll be able to have people really talk to the legislators about the future direction of coverage, care, and access, and things like that. And it can be in the context of a lot of things, I think, that have been happening this year. So look for that, September 11th, virtual or in person. We don't know, but we'll let you know. Be sure that you check out a couple of things. The 2 websites that belong to the IEHP. One is IECHI.org. Like I say, this presentation will be posted on there, along with this recording and the questions and all of that. And the other one that was developed is the IE Rural Health. It's the IEHP Rural Healthcare Task Force, which a lot of our members of our coalition are very involved in this, and that's Kevin Mahaney and Lenny Pepper and Gary Rotto, and I know I'm leaving people out, but it's a wonderful organization that developed a comprehensive study last year that is utilized by numerous organizations throughout the Inland Empire and elected officials and government offices. So IERuralHealth.org, you can get engaged or read up on the latest developments there. And also please check out the IEHP Facebook page. We post a lot of good information there, and we need to grow that and have all of you help us share the information. We're going to share updates about this meeting we had today, and we'd like to notify the community about upcoming events and grant opportunities and things like that. So I don't have the whole string to read you right now, but just if you go to Facebook, just type in IEHP search and it'll get you there. Want to also thank our wonderful wizard behind the curtain who pulls all these strings, does all these things, Victoria Stephen, who is the consultant for the IEHP. And so Victoria, are you, I don't have you on my screen. Let's see. Can you wave at us, Victoria, so we can applaud you. Woohoo! Thank you for all you do. You just keep this engine running and we really, really appreciate you. So thank you. And I see you're muted, so you can't even speak back to us. Okay. Other than that, I think that's it. So we want to thank you all again so much. Thank you to our panelists so very, very much. Dr. Teresa Frausto, Dr. Wendy Vieira, David Bones, and Laurence Gonzaga. That was outstanding information, and we appreciate your expertise and your time today. So thank you, and we'd love to have you back again in the future. So everybody stay safe, stay healthy, hang in there, and let's stay connected so we can find solutions together. So thank you all. Have a lovely afternoon.
Thank you.
Thank
Thank you.
Thank you.
That was great. Thank you.
Bye. Thank
Thanks.
you.
Thank you, everyone.
Thank you.